Hi, I'm Eric Prystowsky. Welcome to another segment of EP on EP. With me today is a very good friend and a major researcher in our field of atrial fibrillation, Dr. Nassir Marrouche, who is currently the professor of medicine at the University of Utah and executive director of the Karma Center. Nassir, there's so many things we could talk about, but you know, you've just published a wonderful trial that's going to influence what we do in the field, the CASTLE-AF trial. And I also want to get a little bit into how you're using that along with some of the research you do with fibrosis in the atrium. So why don't we start for the audience of walking us through CASTLE-AFib, the key points of that, who entered the study, and sort of where we're going.
Thank you, Eric, and it's a great pleasure to be with you here, by the way, a mentor and a leader and a guide to everybody. I have to say it on file.
On file? That's good. A copy of this will go to my family. Go ahead.
So, you know, CASTLE-AF, as you know, both of us, we've been involved, and you've been, you know, guiding us over the AFib research treatment, finding the right treatment for our AFib patient. And finally, the first time in history, we have a way to help the patient with atrial fibrillation, a specific group of patients with atrial fibrillation who are suffering from heart failure, with an ablation procedure that we can really say we're improving mortality and hospitalization, the first time ever. We tried this with drugs. As you know, you were involved in every single study. We failed. Again and again, we could not find any solution, not only for the specific population, for anybody suffering from atrial fibrillation, but now focusing on atrial fibrillation and heart failure population. CASTLE is a study that followed patients over 5 years, included patients with any kind of AFib, low EFs, primary secondary prevention for ICDs. They have to have ICDs or BIVI-ICDs. And obviously we randomized them to ablation versus a conventional heart failure treatment of patients with atrial fibrillation and heart failure. So you could do rate control, you could do rhythm control. And this is important to mention, I mentioned this again and again, that I think the advantage of CASTLE that we did not have more than 20%, 23% of patients taking antiarrhythmics in both arms during that study.
Okay.
Because people, you know, there's a lot of data show that amiodarone or ticosine did not work, or
right. So it was mostly rate controlled.
Rate controlled because of the AF-CHF trial.
Yes.
It was published today, practically the year when CASTLE stopped being, you know, putting, and everyone said, we want to have an option not to give drugs to patients. So we added this into the inclusion criteria. Let's keep this in mind. So 77% of the patient, if you look at the rate control curve during the duration, because of the patient who took rate control strategy, had rate control strategy using beta blockers, calcium antagonists in the pharmacological arm, and the rest had rhythm control strategy in the pharmacological arm. 10% of those, of the whole study population, which is almost 50% of this population rhythm control, went to the ablation arm. Crossed over. So only few patients have antiarrhythmic drugs in the other arm, despite the fact we could show.
So when you say crossed over, that's a large number. At what point and why? In other words, because that does affect the final results. Is it just they were getting worse, or was there a predetermined point that they could cross over?
It's an excellent question. But if you look at the crossover, let's look at the crossover impacting the study in a bad way or a good way.
Okay.
So if you look at the intention to treat, modified intention to treat, per protocol or per treatment, all of them are significant.
Well, that's very important.
And that's important because you have to look at the supplement. The people that say they read the manuscript and they forget there's 40 pages of supplement for the New England Journal that I added or we added as an investigator. So keep this in mind, number one. Number two, we are asked by the author, as you are an author, or you are an editor of a journal, by the editors of the New England Journal to systematically go through this analysis. And there we did. And so the crossover, if you look at the crossover from ablation to the treatment arm wasn't that a major issue, but the issue was the crossover from this arm to this arm with a treatment that showed to be significant and save lives. So we take all the ablation patients only and compare them like other studies did, and non-ablation patients, not the intention to treat per protocol.
Per protocol.
You have way more superiority than the endpoint that we described in the major paper of intention to treat only.
Okay.
So that means that these 18 patients that crossed over, or 10% of the population from the pharmacological arm, they were helped
Yes.
If
So
I left,
even if you went intention to treat, though, you still met your goals.
you still match your goals and the modified intention to treat.
So let me back up a little bit just for people who may have forgotten the entry criteria. These all were systolic dysfunction patients, right?
Yeah, less than 35%.
Less than 35%. So here's the thing that I find interesting. And that is that, we know that not everybody's going to have a completely successful ablation. I mean, there isn't anyone who gets completely successful ablation in this group. Yet, as a group, they did better. So when you delved into it, did they do better because they had less burden? I mean, you must have looked at all those things. Why did they do better?
I think we're going to talk more and more about burden as we come. By the way, Eric, you know that you and me, we're dealing with AFib, and the number one struggle, we walk into the clinic every day, how much AFib does a patient have?
Right.
Now we have more tools to
Right.
send it, but the beauty about Castle AF that we're going to learn for next years to come is the burden, because we have second by second monitoring. As you can tell, the database is huge, and we starting to dissect this as we go. We have some data we'll be talking about as we go as well, more data. But what we know today is the early stages of AFib. If you ablate a patient or treat a patient, the early stages of recurrence, the first 30 days or 60 days
Right.
to 90 days, they are very important predicting outcome. If you have a patient ablated, for example, and you have an AFib recurrence early on, that will impact your outcome by 5 or 10% more AFib within first 30 days is a problem, and the ablation. So
Okay.
when you ablate people, try to keep it less than 10% practically. That's
Okay.
a good message. But the other important message, if you look at, by the way, this is in the supplement as well in the paper, if you look at the comparison of the burden, all side patients, you say 5% more or less, significant difference. 10% more or less, significant difference. 20% more or less, 30%.
I mean burden.
Burden. This is the from
Oh, so
ICDs.
really? So even
Until you hit more than 10%, you lose a significant difference
more than 10% of what?
of burden.
Of burden. Okay.
That means less than 10% is your goal. Right?
Yes.
Does this make sense what I'm saying?
Yeah, it does.
But you have to obviously to analyze in a different way. This is looking at all comers, drugs, no drugs, not the ablation group.
Okay.
But AFib burden, we're seeing it's important. But now we're trying to understand why ablation did work and then which one did not work, and then that's what we're going to read.
So that's what you're looking at. So let me ask you a couple practical questions. So I'm seeing a new patient in my office who has AFib, reasonable good rate control, EF of 30%, non-ischemic dilated cardiomyopathy, and it's kind of like, well, they meet criteria for a defibrillator, but on the other hand, I have an option maybe now to take them to the lab. So would you say we're at a point that you should consider an ablation approach before you'd ever consider an ICD?
63% of patients in Castle, their EF improved to more than.
Well, that's what I'm asking. So
more than 35%.
So is that a reasonable approach to take?
Yes, and this is independent from duration of AFib, by the way.
Right.
So it's independent how long AFib the patient have. There are significant improvement in EF. After the question is, I ask you back as a master in this field, is the patient entered that 30% window?
Right.
Are they already at risk because they were there, or if they come back, they out of the risk of 35%?
Well, it's interesting.
I know that's what we're going to answer for you, by the way, as well.
Yeah, and I'll tell you what I'm doing, just to throw it into your mix. I'm getting MRIs. Obviously you do it on both atrium and ventricle, but I'm getting them, if they have no scar, I will delay the ICD personally, because I get a feeling from your study and from some other things out there that I have a really fighting chance to turn around part of their myopathy, right? I will say if they have a fair amount of scar, I'll be frank with you, I take a little different approach and I consider an ICD. It's not that I wouldn't consider the AFib, but I think there are data to suggest those folks are at risk of sudden death regardless. So that's just where I'm at now. It doesn't mean I won't change in the future.
That's excellent. And if you look at the sudden cardiac death committee who put the guidelines together, they have enough data, but they said let's wait some more. I don't know why.
Yeah.
This is a struggle.
Yeah.
We do the same thing as you. If we see a scar, I don't wait for anything. Just give them an ICD. But if not, I wait. AFib, I ablate them.
Yeah.
And obviously, in Utah we do a lot of fibrosis, and I hope everybody else, like your center now, is getting on board as well. We do fibrosis imaging. We have a lot of data over the years to show, first of all, diseased hearts are getting more fibrosis.
Right.
That makes sense. The question, when they are global fibrosis, atrium and ventricle, and when they're localized fibrosis.
Right.
That's the first differentiation. If it's localized fibrosis, that's a good outcome guy or person that they do very well. The problem is with the ventricle. As the ventricle improves, now we're finding more criteria that these guys may improve, do better down the road. And this could explain that the guys in calcium not do well are the disease, very sick hearts, right? This is advanced fibrotic areas in the atrium and the ventricle.
So,
and we start to differentiate those and rule them out.
right, I was going to ask you that. So let's kind of regroup a little bit because we don't have that much time left. I mean, you've gone through very nicely your study, your outcomes, kind of where you're going. I would ask you just kind of one other thing. You have this advantage, not everybody does, but because you have done so much work with atrial fibrosis, even though you know you're having advantage of the ablation for AFib, there's probably a group that you know it's almost futile to get a good result for the AFib ablation. Would you still at that point fight it because of your results, or would you say it's the results of the ablation are going to be so poor that it's not worth even doing it?
I ask you a question
like
back.
Utah 4 or something.
If you have any treatment, you know going in that your chance of success is 5-10%. Any treatment in medicine,
I wouldn't do it.
You wouldn't do it.
Yeah.
And that's what the data, if you look at 6 years, 5% of the Utah 4 or advanced fibrosis.
Right.
About 20.
So there you're back
20%, yeah. But 60% of the population, every AFib in the world,
Great.
60%, they should be, should given this treatment because the improvement is fantastic.
So you've really moved the field ahead. I thank you not only for moving the field ahead, I thank you for my patience because you've made it clear to me that we need to be more aggressive in this group right up front with ablation, and I think you've done a great service for us for that. And thank you for joining us and educating everyone. It's always great to see you.
Anytime with Eric.
Thanks.